how and Am I audible?
Yes.
Okay, so see, anteriorly you have the urinary bladder, and posterior to that you have the uterus, right?
Yes.
Now, when the size of the uterus increases, it will compress the bladder,
Yes.
right? Now, the bladder has already a very stress because of this increase in the size of uterus. Okay, and you have the sphincter here that can hold up to a certain pressure only, right?
Yes.
This sphincter can hold up to a certain pressure only. After that, this sphincter will fail. It can no longer hold the urine. So you're already having a very high stress because of this increase in the size of uterus. If a further pressure on this uterus increases because of anything, because of any cause of increase in the abdominal pressure, for example, the coughing, sneezing, or anything, or lifting a weight. So if you further increase the abdominal pressure, that can cause the failure of this sphincter, and you can have a stress incontinence in the pregnancy also.
Yes.
This is one thing. Second thing, because of the progesterone, you also have the relaxation of smooth muscles.
Yes.
Again, the smooth muscles of bladder will be relaxed.
Yes.
So that can again lead to the incontinence sphincter, right? Because of relaxation of these muscles in the sphincter, you can again have a incontinence because of that, right?
Yes.
So these two other things, the supine hypotension because of the gravity uterus. Similarly, the stress incontinence can also occur because of the gravity uterus, right?
Yes.
Any doubt, please ask.
No, thank you.
HPL we've discussed already. It is also known as somatomammotropins. Okay, it is released by the syncytial trophoblast. All of the hormones, of course, they all will be released by the syncytial trophoblast. Okay, they basically cause the increase in the insulin production, and also causes the insulin resistance. Okay, so a gestational diabetes can occur. Okay, if the maternal pancreatic function cannot overcome this insulin resistance, right? So basically, the function of this hormone is to preserve the glucose for the developing fetus. Okay, and now the mother need to feed on the lipids, okay, for the energy source, right?
Yes.
So that's about the HPL. Then you have the APGAR score. Okay, so as soon as the baby delivers, you always measure this APGAR score, and the score less than 7, in that case you need to further evaluate the patient for any kind of a damage, okay, for any kind of a, the growth retardation maybe. Okay, so A for the appearance, P for the pulse, G for the grimace, or you can say the reflex or the irritability of the patient. Okay, A for activity, or you can say you can measure the tone of the muscles in that. And finally you have the respiration. If the patient is pink, you call it a score 2 in the appearance. If the patient is slightly pink, slightly blue, you will give it a score 1. If the patient is pale or blue, you give it a score 0 for the appearance. For the pulse, if the pulse is more than 100 per minute, you will call it a score 2. For less than 100, score 1. If you cannot find pulse at all, you call it a score 0. For the grimace, or you can say the irritability or the reflex, okay, if the patient cries and pulls away, you call it a 2 score. If the patient has a very weak reflex or irritability or a very weak cry, that means a weak irritability, you call it a score 1. So a strong cry, pulls away, score 2, weak cry, score 1, and no response at all will gives you a score 0. For activity, we'll measure the tone of the muscles. Active movement will give you a score 2. Okay, if the arms legs are flexed, you will give it a score 1. And if you have a hypotonia totally, you will give it a score 0. For the respiration, if the patient again has a very strong cry, you will give it a score 2. For a shallow, irregular kind of breathing, you will give it a score 1. For no breathing at all, you will give it a score 0. So you will first calculate the respective scores, okay, and then you will calculate those scores. You will add these scores, and you will get the answer out of 10, because the highest score could be 10, right?
Yes.
If you got a score which is less than 7, okay, you will measure two times, okay, one at the 1 minute, and second time at a 5 minute. So 1 minute and 5 minute you measure two times these things, and you will give it a score. at 1 minute and at 5 minutes. If the score is still less than 7 even after 5 minutes, okay, then you need to do further testing to for any kind of a neurological damage. Okay,
Yes.
although I don't think so Steven will ask you this because I've never encountered any question on the APCAR score. Okay, so yeah, just know about the full form: appearance, pulse, grimace, activity, and respiration. Okay, the pink, blue, 220, in between 1, pulse 100, 0, in between it is 1, grimace a very crying and very irritable, 0, no crying, sorry, a very high and a very this irritable give you a 2, no will give you a 0, in between you will have 1. Similarly for the activity, active movement 1, no movement 0, in between you have the 2, sorry, 1. Okay, respiration, strong cry 2, no breathing at all 0, in between you have the 1. Again, so any doubt on the APGAR score?
No, thank you.
No, thank you.
Okay, so menopause we'll discuss later. Okay, so forget it for now. Okay, now the important part, a very important part. Now before that, I think just give me a second. Lactation, menopause. Let's talk about delivery first. Okay, so what happens is at the time of delivery, you first have the labor induction, right?
Yes.
And what hormone gives the labor induction, induces the labor?
Oxytocin.
Oxytocin.
Oxytocin. So whenever the oxytocin is available, it will cause the contraction of the smooth muscles in the uterus. Okay, because the function of progesterone is to cause the relaxation, right? And that will support the pregnancy. As soon as you get the oxytocin, it will cause the contraction of the smooth muscles in the uterus, and that causes a delivery of the baby, right?
Yes.
So does that mean if I give the patient oxytocin at any stage of the pregnancy, okay, think about it. If I give the patient oxytocin at any stage of the pregnancy, I can have the termination of pregnancy of the patient,
Yes.
or you can say the miscarriage maybe, right?
Yes.
MTP,
Yeah.
medical termination of pregnancy,
Yes.
right?
Yes.
I can give the patient oxytocin, right, for the MTP.
Yes.
But I'm sure you never heard any doctor giving oxytocin for the MTP, right? You generally give the anti-progesterone pill, or you give the patient, you give the patient anti-progesterone pill or pro, uh, the prostaglandins pill, right?
Right.
So why not the oxytocin?
It may cause a placenta rupture.
Well, that's
Before
exactly what
delivery.
you want. That's exactly what you want. You want to terminate the pregnancy, right?
It might be before the delivery of the baby, so it might be
No,
typical that
you don't want to deliver the baby. You want to end the life of baby, right? In utero. You want the death, right? MTP. I'm talking about, not normal delivery. Yes.
Repeat the
Okay.
question.
So for the MTP, you just want the baby to be die.
Yes, okay. I missed that.
Oh, it's raining outside right now.
Maybe
So,
due to uterine rupture if it was a high dose.
actually, oxytocin prevents the rupture. We will discuss that later. It prevents a postpartum hemorrhage, oxytocin.
Yes.
So again, apply protective. Because the oxytocin cannot function at all. Before third trimester, oxytocin cannot function on the uterus. See what happens when the levels of the estrogen increases with the gestation age. The other important function of the estrogen is to increase the receptors of the oxytocin on the uterus. Okay.
Increased in the third trimester, the receptors?
Yeah. And the significant level of these, or you can say a significant number of these receptors will be reached only after third trimester. Before third trimester, you have a very little receptors for the oxytocin, right? So even if you give the patient oxytocin, it won't work because you don't have a receptors at all on the myometrium, right?
Yes, yes.
So you require the estrogen to increase the density or the number of these receptors on the uterus, on the myometrium. And that can only be possible after third trimester, in the third trimester. So before third trimester, even if you give the patient oxytocin, it won't cause any contraction in the uterus. Is that okay?
Yes.
Now, other thing is, you know that whenever you got a labor, okay, you got a patient with a labor, they always have very coordinated contraction in the uterus, right?
Yes.
So how this coordinated contraction between the uterus is possible?
By reaction.
Pulsing release of oxytocin.
You have the oxytocin is acting on the uterus, right? And now you're having a very coordinated contraction of the uterus that causes a delivery of the baby. So how does this coordinated contraction occur?
Is there any pulsatile manner of secretion?
No. You guys have studied, and I have mentioned many times this before. Whenever you have a coordinated movement or a coordinated contraction, you did one thing. We have discussed it many times, right? Now
Yeah.
answer that. If you want a coordinated movement of any cell, you want a coordinated contraction of any tissue, what thing you need in that tissue?
Gap junctions.
Gap junctions, exactly. Okay, every cell in the myometrium has a gap junction that connect one cell to another. So as soon as the oxytocin act on any of the cell, the signals will be transmitted to other cells. And that's how you will have a very coordinated contraction in the uterus at the time of labor. Is that okay?
Yes.
Yes.
And again, the development of these gap junctions is dependent upon the estrogen. Okay.
Okay.
So the function of estrogen in the pregnancy on the myometrium is to increase the receptors of the oxytocin and to cause a development of gap junction in between the cells. Is that okay?
Yes.
Yes.
So do remember that about the labor, oxytocin for the labor, but only after third trimester, not before third trimester, because it is not functionable because you don't have any receptors on the uterus before the third trimester. Any doubt, please ask.
No, thank you.
Thank you.
Okay, now let's discuss the developmental milestones of a child. Okay, and you don't need to remember every milestone, but the very important ones you must remember. Okay, for that I've made this simple table. Okay, so first, the milestones before the 12th month are very important. Okay, so we have divided this milestone into 1 month, 6 month, 9 months, and 12 months. Okay, and we will discuss all these milestones under the headings gross motor, fine motor, language, and social and cognition. Okay, these four headings we will discuss. So think about it. When the patient got birth, okay, then within 1 month, he will just can lift his head. Okay, and then at 12 month, he will start walking. Now, before he need to start walking, sorry, before he can start walking, he need to sit up and stand, right?
Yes.
So at the first month, the patient can only lie down and lift his head. Then on the 6th month, in between this 1 month and 12 month, at a 6 month in a very middle, the patient can sit up, okay, without any support. Okay. Then at 9 month, the baby can stand with the support, and then at 12th month, he can walk without support. Is that okay?
Yes.
So just note the two extreme first. Select the two extreme first, which is the lifting of the head and to the walking. In between, you have the 6 and the 9 months. At those months, the baby first need to sit up and then need to stand up, and then only he can walk, right?
Yes.
So lifting is the head, sitting up, standing with the support, and walking. Okay, that is a gross motor function, and these are the milestones a baby must achieve at these months. Okay.
Yes.
Now comes the fine motor. You don't have any fine motor for the first month. Now, but within 6 months, okay, the baby need to achieve the ranking grasp, okay, in which the baby can pass one toy from one hand to other hand. Okay. Then at 9th month, the baby need to do the 3-finger grasp. He need to hold the thing with 3 fingers. Okay. And then at 12 months, he will be able to hold any object with the 2 fingers. So think about it, 2 extremes from palm to the 2 fingers. So at 6 months, the baby need to hold an object with the palm, and it need to be, switch that object between the hands. Then comes the 3 fingers. That means a very fine movement from palm to 3 finger. Then again, a very fine movement from 3 fingers to 2 fingers, right?
Yes.
And that 2-finger grasp is known as the pincer grasp. So these are the
Yes.
fine motor milestones a baby must achieve within 12 months. Okay.
Yes.
Okay.
Now comes the language. Okay. So with the first month, the baby can only smile. Okay. He cannot say anything. But within 12 months, the baby need to say mama and dada plus one another word. Okay. So mama, dada plus one another word. So these are two extremes. In middle, the baby first before saying this one other word, the baby need to say mama dada first, right?
Yes.
So between 6 to 9 months, okay, the baby should be able to say mama and dada. So start with the first month, just a social smile. The baby can only smile after seeing the mama and dada. Okay. Then at 9 months, he should be able to say the mama and dada, one word. Then at 12 months, okay, the baby should be able to say mama and dada plus one another word. It could be anything: eat, sleep, walk, okay, anything it could be. So one another word plus mama and dada. Okay.
Yes.
So this is a language. These milestones a baby need to be achieved. The final ones are the social or the cognitive. Okay. So within 1 month, the baby should be able to identify the parents. Okay. And at 12 months, the baby should be able to do one-step command. If you ask him to sit, he will sit. If you ask him to go, he will go. If you ask him to eat, he will eat. So a one-step command he should be able to follow along with the separation anxiety. Before that, in between, you will have a stranger anxiety. So because now baby can easily recognize the parents, whenever he see any stranger, he will start crying. And that happens after the 6 months. At 9 months and between 12 months, the baby will develop a separation anxiety. That means whenever he go away from the parents, he will start crying. And then at 12 months, along with the separation anxiety, the baby also get one-step command. Like we have discussed, go, sit, and eat. Is that okay?
Yes.
So select the two extremes first, 1 month and 12 months, and then you can easily know what stages the baby need to pass in order to go there. Like from lying down to sit up, then stand, then walking. From hand to 3 finger to 2 finger. From smile to saying mama and dada plus another word. First will be the mama and dada. So smile, mama, dada, then the one other word. For the social cognitive, he should be able to recognize the parents, and then at the very end, he should be able to do one-step command. So he need to pass from recognizing parents to the stranger anxiety, and then to the separation anxiety, and then to the one-step command. Any doubt, please ask.
No, thank you.
Now, so what the step one can do, he will give you a baby, and they will describe you some features in the baby, like he can sit up, or he can say mama, dada. He will having a separation anxiety. He can do a pincer grasp. Okay, so multiple things he will give you. Step one will give you, and they will ask you what could be the age of the patient. Would it be a 1 month, 6 month, 9 month, or 12 month? Okay,
Yes.
so they will describe your features of all these months. Like the patient is having a, this baby is having a stranger anxiety. He can hold the toys in one hand and pass it can to the other hand. Okay, he can able to sit up without any support. And they will ask you what would be the gestational month of the patient. So not gestational month, sorry. What would be
Yes.
the age of the patient? It would be the 6 months. Similarly, they will give you a baby of 6 months and they will ask you what could be the language milestone, or what could be the fine motor milestone, or what could be the gross motor milestone of this baby. So you need to know that these are the milestones a baby need to achieve at 6 months. Okay.
Yes.
Now, any doubt, please ask.
Separation anxiety 9 month, right?
Yeah, in between 9 to 12 months. Yes.
Okay, thank you.
Up to 12 months, he should be able to get the separation anxiety. Okay. And other question could be, they will ask you if the development of the baby is normal or he's having a delayed development. Okay. Because they will give you a baby with the 9 months and they will describe you features of that baby. Okay. If they give you the features of the 9 months in all 4 categories, in all 4 headings, that means a baby is having a normal development. If any of the category, if any of the milestone is not achieved at this 9 month, for example, he can only smile and only can cry at 9 months. He cannot say mama and dad at 9 months. That means you can see that the patient is having a language disorder, right?
Yes.
So these kind of questions will be framed with the developmental milestones. Now, any doubt, please ask.
No, thank you.
Let me open a table for you from the UI for the further milestones. Okay, so we have discussed up to 12 months, and the gross motor, he should be stand well, he should be walk independently, okay, and he should be throw a ball. The important one is to walk independently. Fine motor, two finger grasp or the pincer grasp. For the language, he should be able to say one other word other than the mama and dada, of course. For the cognition, he should be able to get the separation anxiety and should be follow one step command with gestures, okay, like eat, sit, go, walk, other things. Now comes from 12 month, and that means from 1 year to up to 2 years. Okay, so at 1 year he should be walking independently, and at the 2 years he should be walking, okay, on the stairs with 1 feet at a time. Okay, so from walking on the flat floor, the baby should be able to walk on these stairs with one toe, or you can say 1 feet at a time at 2 years. Okay, for the fine motor, from reaching to a two-finger grasp, the baby should be able to build a cube, a tower of 6 cubes, and should be able to copy a line. Okay, then starting from 1 year, when the baby was saying only one word other than mama and dada, okay, now at 2 years, the baby should be able to say two-word phrases like mama go, mama sit. Okay, so two-word phrases he should be able to say, and vocabulary must be more than 50. So at this point, okay, at 1 year, the baby only knows one word other than mama and dada, right?
Yes.
But at 2 years, baby should be able to say 50 different words with a two-word phrases. Okay,
Yes.
so 2 years, two-word phrases. So these are two extremes again. For the social cognitive, from separation anxiety and from following one-step command, at 2 year, the baby should be able to follow a two-step command. He should be able to begin a parallel play where he see other child and play accordingly with them. Okay. Now they should be able to begin the toilet training. Okay. So this is the two extreme again. In between, okay, from walking independently to walking on the stairs, he need to run first and kick a ball. So throwing a ball, kicking a ball, walking, running, and then walking on the stairs. Right?
Yes.
Yeah.
So again, select the two extremes first and then go in the middle. Okay. So at the age 12, he should be walk, he should be throw a ball. At 18 months, he should be run, he should be kick a ball. At 2 years, he should be go up and down stairs and jumps again. For the fine motor, from two finger grasp to reaching the tower and to building a tower for the with the 6 cube, he should be able to build a tower with the 2 to 4 cubes. Then he can destroy 6 cubes, and he should be able to remove the clothes first, and then he can draw the line. Right? From language, from saying only one word to reaching to the 50 words, he should be able to reach 25 words first, right?
Yes.
So in between, that means at 18 months, he should be able to know a vocabulary of 25 words and should be able to identify one body part. Then for the social cognitive, from reaching the suppression anxiety to reaching this, from following the one-step command and suppression anxiety to reaching to the two-step command and parallel play, he should be able to understand what's mine. Okay, and he should be able to begin a pretend play. Okay, like the imaginative type of play, right? Could be.
Yes.
Okay, he pretends that he's playing. Okay, so pretend play, then the parallel play. Okay, so at 2 years, everything is two. Most things are two. That means a two-word phrase. Okay, the 2 multiplied by 25. That means a 50-word vocabulary. Okay, a two-step command, parallel play. Again, a two lines you can imagine going parallel. So again, a parallel play and a toilet training. So all these are happening at the 2 years. In between, you have the 18 months. Running, kicking a ball, building a 2 to 4 cube towers. Okay, removing the clothes, vocabulary of 25 words, pretend play. Is that okay up to here?
Yes.
Now, then you have the third year. Okay, in the 3 years, because at 2 years, the baby is walking on the stairs with 1 foot at a time, right?
Yes.
In case of third year, he should be able to walk on the stairs with the alternating feet. Are you getting my point?
Yes.
Yeah.
And at third year, he should be able to ride a bicycle with the 3 tires. That means a tricycle. Again, 3 and 3. So riding a tricycle, walking on the stairs with alternating feet. From copying a line, now he can copy a circle. He can use as utensils also. From 2-word phrases at 2 years, he could be at 3 years, he could be able to say the 3-word sentences. And now speech will be 75% recognizable. Okay. And at the age of 3 years, he know what gender he is, male or female. Okay. Imaginative play will begin at that time. Okay. At 4 years, from walking to the stairs up, alternating feet, he should be able to balance on 1 foot. Okay.
Okay.
And you can remember the fine motor by the mnemonic hip hop and copy across. So at 4 years, he should be able to do a hip hop and a copy across. So hip hop, that means standing on a 1 feet. That is the
Yes.
cross motor. For the fine motor, he should be able to copy across. Speech is now 100% cognizable with a 4-word sentence at 4 years. Okay, and he should be able to start playing with the other kids. Please note, only after 4 years, the baby start playing with other kids. If you see a baby who is hitting other child, okay, before 4 years, it's totally normal because the baby don't play with other babies, right?
Yes.
Only after 4 years, only after 4 years, this year they will share their toys and they will do a cooperative play with others. Then at 5 years, he should be able to do a skippings. Okay, he should be able to copy a square and should be able to tie the shoelaces. Okay, he should be able to dress himself. See, at this 18 months, he's removing the clothes. He should be able to remove the clothes. At 5 years, he should be able to dress himself. Okay, he should be able to count at 10 for the language. And at the social cognitive, he has friends. He's socially engaged now. Right?
Yes.
So there's no easy way to learn these milestones. You need to do that every day, memorize them every day, and then eventually we'll learn these. Okay, so just remember them like a story. Okay, select the two extremes first and then go in the middle to see what could be happening. If a patient want to reach from this milestone to this milestone, he need to pass through this milestone first. That's how you can drill them, right? For the 3 and 4 years, it is very easy. For 3 years, a tricycle, circle, 3 words again, and gender. For the 4 years, hip hop, copy across, 100% speech tokenizable, and the cooperative play. 5 years is the least important one, or very easy also. Skipping, tying a shoe, square copying, counting 10, and friends. Important ones are the 12th month, 18th month, and 2 years, and before 12th month. Those are the very important ones, okay?
Yes.
Any doubt, please ask.
No, thank you.
Let's go back to the first aid again. So that's everything the first aid has mentioned here. Okay. The social smile, the stranger anxiety, then the separation anxiety. Okay. Then the object permanence, orientations with the voice, wording. You should be able to use 50, 200, recreation, reapproachment. It's all kind of a mixed up. Okay. So for the simplified version, you can use the U world. Okay. So that's about everything on the child development milestones. Why these things are important? Because they will give you a patient, and in a normal life also, if you encounter a patient in the clinic who is not meeting developmental milestones, he can either having a specific learning disorder, or he can having a global developmental disorder, right?
Yes.
He can have a global developmental delay, in which failure of all 4 categories that we have discussed, gross motor, fine motor, language, and social cognitive, they all will be delayed. Then you can say the patient is having a global developmental delay. If the child is meeting, at every level, every milestone, except one, you can say a specific learning disorder is present in the child, right?
Yes.
So that's all on this page. Please ask if there is any doubt.
No, thank you.
Okay. Then let's discuss the accessory nipples. Okay. What happens is, at the time of intrauterine life, you have multiple nipples throughout the body, as you can see. It starts from the mid-axillary line here and go up to this part of the pelvis, right? So all these nipples are present in the intrauterine life, but then these all nipples will be regressed or will be obliterated after the birth, right? So only one nipple is present. Now what happens is, sometimes you have the failure of involution of this mammillary ridge. You got this line, you see this mammillary line, this is known as a mammillary ridge. Sometimes you have the failure of involution of this mammillary ridge, right? And as a result, some accessory nipples are also present. Okay, and when you examine that, it will be appear as a normal nipple. They will be hyperpigmented. Okay, they will increase in the size with the puberty. Okay, the findings include a hyperpigmentation. When you see on the examination, when you examine this kind of, the patient will present you with some kind of a bump on the skin, on some kind of a mass on the skin. Okay, and that mass will become very painful shortly before the menses, at every cycle, every month. And when you examine this mass, what you will see that the mass is hyperpigmented. The mass is having an endometrial, this epidermal thickening. The mass also has the areola. Okay, and the mass can even has a possible mammillary glands. Okay, so patient will present you with a congenital bump on the chest. Okay, that bump will become very much larger and painful just before the menses, and just before the puberty. This mass has become larger. It is soft, raised, and hyperpigmented mass. They will tell you about this line, that it is shortly below the breast, or above the breast, or at the axilla part, or at the pelvis part also, right? Examine the mass, know the history of the patient. You will know that this patient is having a accessory nipple. Is that okay?
Yeah.
Yes.
Now after the birth, when deliver the baby, the patient will have a lactation. Okay, lactation happens because shortly after the birth, the level of the progesterone will be decreased, and that causes a disinhibition of the prolactin that causes the initiation of the lactation. Please note, the suckling is always required for the lactation. If the baby don't suck, okay, then in that case, the prolactin does not causes the release of milk, or you can say the formation of milk, not the release, but the formation of milk. And as a result, if the baby did not suck for some time, the patient can have the return back of all the these menses again. Okay, because the levels of prolactin will decrease if the baby do not suck. Okay, so as long as the patient is breastfeeding the baby, only then they can have the lactational amenorrhea, right?
Yes.
Yes.
If the female stop the breastfeeding, in that case they will have a return back of normal cycles again. Because if the baby do not suck, then in that case, the milk ejection, milk production does not happen. Production of this milk will be decreased. Level of the prolactin will decrease. And after some time, the patient can have a normal cycles again. And please note, two hormones are involved for the lactation. One that forms the milk and second that releases the milk. The formation of milk is dependent upon the prolactin and the release of milk is dependent upon the oxytocin. So prolactin will act on the cells and releases the milk there, and the oxytocin causes the contraction of the smooth muscles in the breast that causes the release of milk. Is that okay?
Yes.
Yeah.
And like I told you, with every body secretion, you have the IgA antibody in it, like the saliva, tears, sweating, right? Breast milk. They all have the IgA, and that's why it is known as a secretory antibody. Remember?
Yeah.
In case of lactation, also again, you will have the IgA antibodies in it. Okay, you have many macrophages, lymphocytes that provides the immunity to the baby. So, and that's why the breast milk is the ideal nutrition for infants with less than 6 months. Okay,
Yes.
so a breast milk will reduces the risk of developing the asthma, allergies, diabetes mellitus, obesity to a child. Okay, and please note, if the baby is on a breastfeeding, then they can have a deficiency of vitamin D. Okay, so at a very initial time, before 6 months, before 3 months, you can say, you need to give the patient vitamin supplement, because the baby are not exposed to sunlight much more, right?
Yeah.
And their skin is mostly covered with the clothes at all the time, right? So because of decrease in the exposure of the sunlight, and second, because this breast milk is not uh, has a very significant level of this vitamin D, that's why you need to give the patient vitamin D after 3 months. I'm not exactly sure at what month to give it. Let me check. Give me a second. Yeah, 3 months. So up to 3 months, the vitamin D is normal. So after 3 months, you need to give the patient vitamin D if the baby is still breastfeeding. Up to 4 or 5 months, the amount of iron in the milk is normal for the baby's growth. But after 6 months or after 5 months, if the baby is still breastfeeding, you need to give the baby iron supplements also. Is that okay?
Yes.
And please note, as soon as the baby delivers, because they do not have any GI flora, you need to give them the vitamin K also, right?
Yes.
So shortly after the birth, vitamin K, 3 months, vitamin D, and 5 or 6 months, iron. These supplements are required for a breastfeeding infant. Is that okay?
Yes.
If the baby is on a formula feed therapy, okay, if the baby is a formula feed infant, then they do not require any vitamin D supplement or iron supplement because that milk is already very much fortified with these supplements, okay?
Okay.
So these formula feed infants, they do not require any kind of a supplement except the vitamin K, of course. Only the vitamin K is required, no vitamin D, no iron, okay? Please note that the breastfeeding will decrease the risk of having a breast cancer and the ovarian cancer, and it facilitates the mother-child bonding. This bonding. And why does the breastfeeding decreases the risk of breast and ovarian cancer?
Estrogen decrease. Estrogen.
Yeah, because of the estrogen, right? I told you the endometrial hyperplasia. Hyperplasia can always lead to a cancer, right? If you guys go back to general pathology, you will see that the hyperplasia can lead to the cancer, right?
Yes.
Yeah.
So, not just the breast and the ovarian cancers, but also uterine cancers, right? The risk of these cancers will be decreased. So, breast, ovarian because of loss of estrogen, and the endometrial cancers also. You will have a decreased risk with the lactation. Remember that also. Now you have the menopause. At what thing? In what patient you will call the patient is having a menopause? Whenever the patient is having a amenorrhea for the 12 months. That means for up to for over a year. If the patient do not have any cycle, you will call that the patient is having a menopause. And just before this amenorrhea, okay, patient will also have a preceding 4-5 years of abnormal menstrual cycles. So before the menopause, that means around the age of 50, the patient started having this, these abnormal kind of cycles. Okay, irregular cycles will be having 4-5 years. Then suddenly the cycles stop, and now even after 1 year, the cycle do not return, and you call it a amenorrhea, menopause. Okay, the average age is around 51 years. Okay, it could be 55 also. 51 years according to first state, it is the average age was the menopause. So that means around at the age of 45 or 46 years, the patient started having these abnormal menstrual cycles, right? And then averagely after 51 years, the cycles won't return even after 12 months, and you call it a menopause. Okay.
Yes.
Now see, let me cover this. Okay, let's talk about what hormonal changes you will get when you get the menopause. Okay, so what is the first thing will be happening? Loss of estrogen, right?
Yes.
When the
Yes.
estrogen is losing, what will happen? Tell me.
Endometrium
about
will
it.
grow.
What about different? See, the
We will
first
lose
thing.
that effect of estrogen in multiple tissues that we
Yeah,
mentioned: the breast,
This-
the bone, the ovaries.
Osteoporosis.
yeah, that is a further thing. Let's keep it for later now. See, menopause is because of loss of estrogen, right? So the primary thing that is happening is the loss of estrogen. Okay.
Yes.
Now, what about the level of LH and FSH?
Increase.
Will increase.
Increase. The level of LH and FSH will increase. And please note, the level of FSH will increase more than the LH.
Yes.
Okay, and as a result, a sudden rise in the level of FSH, a very much increase in the level of this FSH, is a very specific thing for the menopause. Okay, because of loss of negative feedback. Is that okay?
Yeah.
Yes.
Now, tell me one thing again. Because you're having a loss of estrogen, but you're still having the these androstenediones, right?
Yeah.
So because you're still having the androstenediones, but you're not having the estrogen now, because these androstenediones are not converting into the estrogen. What will happen now?
Increase androstenedione levels.
Yeah, you will be having an increased level of androgen, and what will it cause?
Hirsutism-like features.
Male.
Yeah, what this thing called term?
Hirsutism.
Hirsutism. Yes, you're gonna have the hirsutism. What about the GnRH?
Increased.
Increased. Yes. And now because you're losing the estrogen, what other things you can have other than these hormonal changes?
Bone weakness,
Bone
Osteoporosis,
weakness, osteoporosis you will get. What about the vagina?
dryness,
Dryness, atrophy of the vagina you will get, right? What about the CVS?
coronary artery disease, heart.
Why?
estrogen estrogen it itself reduces LDL and increases
Yeah,
the HDL.
exactly. Estrogen reduces the LDL level, increases level of HDL.
HDL.
Because of loss of estrogen, the patient will be at an increased risk of developing the coronary artery disease because of low level of HDL and high level of LDL. Sleep disturbances can also happen, right?
Yes.
And yeah. And what is the most important this estrogen after the menopause?
Estrone.
Estriol.
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 Estrone. ONE.
Estrone. Estriol. Yes, estrone it is, right? And where does this estrone released from?
Adrenals.
Not from the adrenals.
Fat.
Fats, exactly. The adrenals, the cortex will release the androstenedions or the androgens. This androgen will enter into the blood, and into the blood it will go to the fat tissues. From the fat, it will be converted into the estrone. So after the menopause, this estrone become the major hormone in the patient, right?
Yes.
So that was all about the menopause. So now let's discuss what the FAS shared. Okay, so this amenorrhea because of decrease in the estrogen production, call it a menopause. In that case, because with every and with the age of the patient, you always be having a decrease in the number of ovarian follicles. Finally, all these ovarian follicles will die, and you will have a menopause because of that. Average age of onset is 51 years. You can have a preceding 4-5 years with the abnormal menstrual cycles, of course. Source of estrogen is now become the estrone, which is after the menopause. It is because of the peripheral conversion of the androgens. Okay, because the conversion is now decreased, you will be having an increased level of androgens that can cause the hirsutism in the female also. Because of loss of negative feedback, you will be having a high level of FSH when it is very specific for the menopause, right? Low level of estrogen, a very high level of FSH, slightly increased level of LH, and slightly increased level of GnRH. These are the lab values you will see in a patient having a menopause. Symptoms, hot flashes can happen, atrophy of the vagina can happen, osteoporosis can happen, coronary artery disease can happen, sleep disturbances can also happen. A menopause before the age of 40, it is suggestive of the primary ovarian insufficiency, which is the premature ovarian failure. That can be happen most importantly after the chemotherapy or after the radiotherapy. Because I told you, by giving the patient radiotherapy or the chemotherapy, you're killing all the cells which are rapidly dividing, right? All these stem cells, all the germ cells, they will die, right?
Yes.
So a premature ovarian this failure could be seen in a patient receiving a chemotherapy or a radiation therapy. With the radiation therapy, what damage can happen? What kind of a damage can cause by the radiation therapy?
DNA damage.
What kind of a damage?
DNA breaks.
Okay, DNA breaks. And how does this happen?
From dimers.
From?
Reactive oxygen species.
Exactly, reactive oxygen species. Remember?
Free radical.
It causes the oxidation of the proteins, oxidation of the lipids, and oxidation of the DNA also, right? Causing a strand repair and this breakage of the DNA strands, right?
Yes.
And that can lead to death of the cell. Fibrosis can happen in the in your ovarian. That can lead to the premature ovarian failure. Is that okay?
Yes.
Yeah. So that's all about the menopause. Any doubt, please ask.
No, thank you.
No, thank you.
No, excuse me.
Yes.
Estrone will be converted peripherally to androgen.
Sorry, repeat it again.
The main cause of hirsutism, what is it? And after menopause,
Increased level of androgens,
that is
because you're having
coming
a less
from.
androgens,
Yes.
adrenal cortex, zona
It
reticularis.
yeah, it isn't from estrogen peripherally.
Yeah, these androgens will convert it into the estrogen peripherally, right? But this conversion is not very much as you see in the ovary. This conversion is not that much higher, right? It is very little conversion only. Okay.
I mean that fatty tissue will release estrogen, right?
Yeah, exactly.
Will that estrogen convert to androgen or not?
Estrone
Yes.
will convert into androgen, you're asking?
Yeah, is that what's happening?
No. Androgens are converting into estrone, not the opposite.
Okay. So
See,
the first
the
thing,
cortex will release the first thing is the cortex, this reticularis, the zona reticularis, it will release the androgens, androstenedions, right? And
yes,
these androstenedions, they will they will enter into the blood vessel, go to the fat tissues. In the fat tissues, these androstenedions, they will convert into this estrone.
okay,
So androgens first, estrogen later,
okay.
not the
Thank you.
opposite. Okay.
Okay.
So let's take a short break and then discuss the androgens. Okay.
Okay. Thank you.
Androgens, different type of androgens you have are the testosterons, the dihydrotestosterons, and the androstenedions. Right. The sources includes the DST and the testosterons by the testes, androstenedions by the adrenal glands, the zona reticularis. Right. For the potency, the DST is the most potent. Then comes the testosterone, and finally you have the androstenedions. Okay, so for the functions, okay, testosterone, let's discuss. Okay, they help in differentiation of the epididymis, vas deferens, seminal vesicles. If you guys go back to the embryology part, we have discussed about the Wolffian duct, right?
Yes.
And I told you that the growth or the differentiation of this Wolffian duct is dependent upon the testosterone's level, right?
Yes.
Yeah.
So without testosterone, you do not have the growth of the Wolffian duct. You cannot have the differentiation of the internal genitals, right? Then second is the growth spurt. Okay, the growth spurt, that means the penis growth, the seminal vesicles, sperms, the growth of the muscles, and the RBCs is dependent upon the testosterone. So whenever you have a high testosterone, that will give you a muscle mass, and it also increases the RBCs. If you give a patient testosterone therapy, that will increase the mass of the RBCs also. The hemoglobin count will increase, hematocrit will increase, and that can lead to the hyperviscosity in the patient also if you give it in too much amount, right?
Yes.
Yes.
So that can give the patient hyperviscosity symptoms like the blurring of the vision, for example, right? You can also have the ulcers because of this decrease in the blood flow because of increase in the viscosity, right?
Yeah.
Yes.
So these are the symptoms patient will get if you give them the androgen therapy. Okay, or non-controlled androgen therapy. Muscle mass, a lean muscle mass will increase because of
Excuse me,
that.
sir.
Yes.
Did you say that it will give them ulcers? I think I missed something.
Ulcers, the gastric ulcers, right?
Okay.
Because one of the
Oh.
cause of the gastric ulcers is to decrease the oxygen, right? You need the nutrients, you need the prostaglandins to maintain the GI mucosa, right?
Oh.
If the blood is decreased to the GI mucosa, what could happen? Hypoxia, ischemia, right?
Okay. Yes.
So because of increase in the viscosity, that will lead to a decrease in the blood flow that can lead to the ulcers also.
Okay.
Similar thing can also happen in the polycythemia vera, the tumor, right? The tumor of RBCs.
Okay.
Yes.
Yes. Thank you.
Okay. So, other thing is a deepening of the voice. It causes the growth of the voice box. That causes a deepening of the voice. That is the androgen again. Okay, androgen, because they're converted into the estrogen. I told you that estrogen act on the epiphyseal plate to cause the bone growth, but at the same time, it also closes the epiphyseal this plate, right?
Yes.
So initially, these androgens, the testosterone, DST, and the androstenedions, they will increase the bone growth, but at the same time, because they're closing it, after some time, they will close this growth plate also. Okay, so if the patient got too much of androgens at a very initial part of the puberty, they will have the growth spurt. They will become very tallest in the class. But at the end of the puberty, they will become shortest in the class. Okay.
Yeah.
Other thing is the libido. It is also controlled by the androgens. If you have testosterone, you will have the libido. If you don't have the testosterone, you won't have any libido. Bone mass again will be increased because of the estrogens. Other function, the dihydrotestosterone, okay, they basically help in the differentiation of the urogenital sinus, tubercles, and the folds, remember?
Yeah.
So basically they help in the differentiation of the prostate, the penis, and the scrotum. In the late part, they can cause the prostate growth. And because, and that's why whenever you have a benign prostate hyperplasia, you will give them the anti-androgen therapy, anti-DHT therapy, 5-alpha reductase inhibitor, the finasteride, remember?
Yes.
Because it is inhibiting the growth of the prostate. Second thing, the male pattern baldness, it is also caused by the high level of DHT. So as a treatment for the baldness, you also give the patient finasteride. Again, sebaceous gland activity will be increased after giving the patient DHT, and that causes the acne in the patient. I told you whenever you have an increased sebaceous or decreased drainage of the sebaceous, you can have an acne, right?
Yeah.
So increase in the activity or increase in the production of the sebaceous will be done whenever you have a high DHT, and that's why as a treatment, you can give the patient anti-androgen therapies. Okay.
Yes.
Now, so let's discuss again for the CVS. I told you it is increasing the hematocrit by increasing the RBCs. Polycythemia can happen. Okay, opposite to my estrogen, these androgens can increase the LDL and decrease the HDL. Exactly opposite to the estrogen. In the skin, in the derma, okay, these androgens will increase sebum, causing the acne. In the genitourinary functions, the sperm count will be if you give the patient external androgens. See, what happens is you need the production of the androgens or the testosterone by the Leydig cells, right?
Yeah.
And now this testosterone, it can enter into the seminiferous tubules for the formation of sperms. If you give the patient external androgens, what will happen? These external androgens will inhibit the LH and FSH.
Yes.
And as a result, the LH cannot act on the Leydig cells to release the testosterone. You cannot have, and because you're losing the FSH also, because I told you the inhibin can only give a negative feedback to the FSH, but this testosterone can give a negative feedback both to the both to the hypothalamus as well as pituitary, right? So a drop in the level of both LH and FSH will be seen, right?
Yes.
So basically, if you give the patient external these androgens, external testosterone, what will happen because of increase in the level of this testosterone, you will be having a low level of LH and FSH. Low level of LH will cause a decrease in the internal androgen production by the Leydig cells, and decrease in the FSH will decrease the activation of Sertoli cells, and as a result, you will be having a decreased production of testosterone binding proteins in the seminiferous tubules, right? No?
Could you repeat it once?
We have discussed already Sertoli cell function. What was the function of Sertoli cells?
To
It
regulate.
has four secretory function and one protective function, we said.
So four secretory functions are what?
Molecular inhibiting factor,
Okay, inhibin, amylin,
aromatase,
aromatase, and
Mullerian inhibiting factor,
okay, and
Androgen binding proteins.
so
yes,
if you do not have androgen binding proteins, can you have the concentration of testosterone inside my seminiferous tubules?
No.
So if you're inhibiting the FSH by giving the patient external testosterone, can you have the concentration of testosterone inside seminiferous tubules?
No.
So that will cause a decrease in the sperm production,
Okay.
and that can lead to a testicular atrophy also. So giving the patient external androgens You will have a decrease in the testosterone concentration inside the seminiferous tubules because of loss of sertoli cell function, and that can lead to the decreased sperm production and the testicular atrophy again. Hypogonadism can happen. For psychiatric symptoms, patient will have an increase in the aggression. The patient become very much aggressive, very much irritable. They involve in fighting and all if they takes the external testosterones. In the breast, all these androgens, the external androgens will be converted into the estrogen, and estrogen will cause this growth of the breast, right? So by giving the patient external androgens, patient can also have the gynecomastia, right?
Yeah.
Now, other things basically are, like I told you, the growth plate. It will cause the closure of the growth plate. Deepening of the voice can be happen. Creatinine could be increased because of increase in the muscle mass, right?
Right.
So these things will happen whenever you give the patient external androgen. So a patient having an androgenic steroid abuse, you will always have these kind of symptoms in the patient. Okay, fat-free mass will be increased, muscle strength will be increased, performance will be increased. They have a change in behavior. They will become very much aggressive, gynecomastia. Hematocrit will be increased, hemoglobin will be increased. They will have a suppression of the hypothalamic pituitary gonadal axis, and as a result, loss of GnRH, loss of LH, loss of FSH. That leads to a decrease in the intratesticular testosterone production. That lead to a decrease in the concentration of testosterone inside seminiferous tubules, causing the decrease in the sperm count and the oosiospermia, the azoospermia. Okay, if a woman can abuse these androgens, she can have a virilization, acne, hirsutism, breast atrophy can happen, and male pattern baldness can also happen in these females. Is that okay?
How it can cause gynecomastia in male and breast atrophy in female?
Because you do not require the estrogens in the male, right? But you do require the estrogens in the female. It's all about the concentration. You need high concentration of estrogen in the females and a very low concentration of estrogens in the male, right?
Yes.
If you give the
And
patient, a male patient, androgens, they will have a high concentration of estrogen than required. What is required actually, right?
yes.
Because of this increase in the estrogen, they will have the gynecomastia. In case of female, they have an increased androgens now, more than the estrogen. That causes the atrophy.
Okay, the external androgen will not affect the estrogen level. It will only make imbalance between the.
Yeah, exactly. See, what happens is, let us suppose there is this level of androgens in the male and the female, for example. See, what happens is, in the females, you require this level of estrogen, okay? And in the males, you require this level of androgens, okay? In females, you require this level of androgens, and in male, you require this level of estrogen, okay?
Yes.
By giving the patient external androgen therapy, what's happening is, in males, let me draw this line, here is a male, here is a female. If the male got an increased estrogen level more than this limit, they can have a gynecomastia because of that. See, the estrogen is still less than these androgens, but higher than what is required, right?
Yes.
That can cause a gynecomastia. In
Okay.
females, the level of androgens will increase, although less than the estrogen, but they still have an increased level of androgens, higher than what is required, and that causes the atrophy. Okay?
Okay. I have another question.
Yes, ask.
Will the external androgen in male affect the Leydig cell and do a negative feedback inhibition and decrease the testosterone secretion or not?
See, these I told you, these external androgens will give a negative feedback to the pituitary and the hypothalamus, right?
Okay. I got it.
It doesn't matter where you're having the androgens. If you have the androgens in the blood, they will give it a negative feedback. That will suppress
Okay,
the GnRH, LH, and this FSH, and that is why you're having a decrease in sperm count, right?
yes. So the low testicular size and the hypogonadism result from both Sertoli and Leydig cell
Yeah,
hypofunction.
atrophy of both the Sertoli cells as well as Leydig cells.
Okay.
Their atrophy will happen. You do not have the sperm production. That will lead to a testicular atrophy.
Thank you.
Okay, so that's all about the androgens. One more thing, the testosterone will be converted into the hydrotestosterone by the action of 5-alpha reductase. This enzyme inhibitor is the finasteride. Okay, And please note that the androgens are converted into the estrogens via the aromatase, which is a cytochrome P450 dependent. Please note this fact. While discussing the pharmacology, we will discuss this fact again. Okay, and I will tell you many other facts related to this one. So please note the cytochrome P450 dependent enzyme it is, aromatase. Okay. And does anyone remember the inhibitor of this aromatase? Name
Letrozole.
and anastrozole. Yes.
Yeah.
Okay, so these drugs are again cytochrome P450 dependent. They require the activation to convert into the activated form so that they can inhibit the aromatase. Similarly, all the receptor modulators of the estrogen, they're again dependent upon this cytochrome P450. We will discuss that later, don't worry for now. Okay, so just know this aromatase is actually a cytochrome P450 dependent enzyme. Okay.
Yeah.
So that's about the androgens. Now, what changes will you see in a patient with the aging, in a male patient with the aging? Okay. So in a male patient with the normal aging, they will have a slow reduction in the gonadal testosterone production. Now, as a result, the level of both free as well as a total serum testosterone will decrease. Because of a decrease in the level of testosterone, you will be having a high level of luteinizing hormone. Okay.
Yes.
Negative feedback, right?
Yes.
This testosterone will convert into the estrogen that will increase the compensatory levels, a compensatory increase in the steroid hormone binding globulin will occur, so that a total level of this of this testosterone could be increased, afforded by the body. So the level of LH will rise, level of steroid hormone binding globulin will rise. Symptoms include the decrease in the ejaculation volume because of loss of the testosterone. Erectile dysfunction can also happen. The erectile latency will increase. It will take time to get an erection. Okay. Sexual refractive time will also increase. That means a time between different orgasms will be increased. If the one orgasm is in 5 minutes, other orgasm will be in the 30 minutes, and other will be in the 1 hour. Okay. So time from one orgasm until the another orgasm, it will be increased, and that is a sexual refractive time. The time to achieve a erection, it will be also increased. Ejaculation volume will be decreased. Erectile function will be decreased. These are all the changes you will see with the aging. Is that okay?
Yes.
So we have discussed previously in the renal part about the changes in the kidney with the age. In this part, we have discussed all the changes you will see with the aging in the gonads. In the hemong section, we have discussed all the changes you will see with the aging in the bone marrow, right?
Yes.
So at the very end, we will compile of all the changes you will see with the aging. So please note, okay, keep these things in the mind.
Okay.
And yeah, that would be all on this page. Please ask if there is any doubt.
Could you please explain how there is increase in the sex hormone binding globulin? See, because of the low testosterone that we have.
See, you have a low testosterone and you have an increase in the level of estrogens in the male. Okay. Now your body to compensate for every drop in the level of testosterone, right? Because you're having a low level of free as well as binded testosterone. Okay. You need to increase that level, right?
Yes, I got it now. That's like
yeah,
like iron deficiency, like in
yeah,
microcytic.
exactly.
Okay, I got it. Thank you.
Okay, any more doubt on this page?
No, thank you.
No, thank you.
Okay, now comes the tenor stages. You need to remember every tenor stage. Okay, so let me open a file that make this very much simpler. Okay, so please see here in the first stage first that you have, give me a second. Yes. You have 5 stages: stage 1, stage 2, stage 3, stage 4, and stage 5. In males, you measure the size of the penis, scrotum, and about the hairs you will get. In the females, you measure the size of the breast and the hairs. Okay, and then you will decide at what stage that patient is right now: stage 1, stage 2, stage 3, stage 4, or stage 5. Okay, and so let's discuss the stages. So you have an age of the patient. Okay, first age is 8 years old, then 11 years old, then 13, then 14, and then 15. Okay, now before the 8 years of age, the patient will be in the stage 1 of the Tanner stages. Before the age of years, this 11 years, the patient will be in a stage 2. Before the age of 13 years, the patient will be in a stage 3. Before the age of 14 years or 15 years, this patient will be in a stage of 4. Okay, and before and sorry and after 15 years, the patient will enter into the stage 5. So see the corresponding number: 1 plus 1 2 is stage 2. Before 8 it is 1, 3 for 3, 4 for 4, and after 5 you have the stage 5. Okay, so this is an easy way to learn. For the stage 1, 8 years; stage 2, 11 years; stage 3, 13 years; stage 4, 14 years; and stage 5 after 15 years. Is that okay?
Yes.
Yes.
Now in the stage 1, the patient do not have any pubic hair, no breast bud, and the patient will be flat chest. Okay, they do not have any kind of this raised in the chest, right? A flat chest will be there. Now when the patient enters the stage 2, that means after the 8 years, before the 11 years, okay, the patient will start developing the pubic hairs, and the breast bud will also appear. Okay, then comes the stage 3. That means between the 11 years up to the 13 years, patient will have the pubic hairs, breast bud. Along with that, patient also have a coarse pubic hair. At stage 2, the pubic hairs start just developing. Okay, and at stage 3, these hairs become very much coarse. Okay, then comes the stage 4, where you have the pubic hairs, breast bud. Above that, the patient will also have a coarse hair. Then patient also have the areola raised. Okay,
Yes.
so
Yeah.
a raised areola with nipple along with the pubic hair. Okay, and all this coarse pubic hair, I must say, the patient will be entered into the stage 4, that is between 13 to 15 years or 13 to 14 years is approximated for the ease of learning. Okay, 4 for 4. Then after 15 years, patient will enter into the stage 5, where they have a proper breast development. They have a flattening of this areola. See, in stage 4, the areola is raised. In stage 5, the areola is flattened. Patient also have a pubic hair along with the hairs on the thigh. In all of these stages, patient do not have any hair on the thigh. Only in the stage 5, patient will get a hairs on the thigh. Is that okay?
Yes.
Yeah.
Now, although these standard stages 2, okay, uh, a patient, that means he's entering the stage 2, that means he's entering into the puberty, right? Because only after age 8, the patient can have a puberty, as you can see, right?
Yes.
After 8 years of age and before 11 years, the patient is in the stage 2, and she or he is in the puberty stage. At that point, the pubic hairs will develop, breast buds will appear, right? So although the Tanner stage 2 will mark the beginning of the puberty, it does not mark the beginning of the menstruation. Menstruation can happen between 10 to 15 years and average of 12 years. It can happen anywhere at that time. Even though the patient is entered into the puberty, it doesn't mean she started having the cycles yet, right?
Yeah.
Yes.
So step 1 will give you a vignette, a patient having a stage 2 uh, of these stages, and they will tell you the patient does not yet started the menstruation, and they will ask you if that what statement should you give to the patient, to the and to the guardian. So they will so he will tell you, even though the this patient is not yet menstruating, it is totally normal. okay, the patient is in a normal development, okay?
Right.
Yes.
That thing you will give. So step 1 can ask you this fact, that the menstruation and this puberty is not the same thing. Puberty can happen after the 8 years, okay, but the menstruation can happen between 10 to 15 years at any time at that, okay?
Yes.
Now step 1 will also ask you what is the earliest change you will see whenever a patient hits a puberty. And please note, in the girls, in the females, it is the breast bud development, okay? The breast bud development will mark the earliest change whenever a patient enters into the stage 2, or you can say enters into the puberty. In males, it is a testicular enlargement that marks the beginning of the puberty. Is that okay?
Yes.
So let's go back to the first aid again and try to learn all these stages. See, in stage 1, in both males and females, you don't have any sexual hairs, flattened chest, okay, and slightly raised nipple could be there, okay, as you can see. So everything is normal. You call it a pubertal stage. Then the patient hits the puberty in the stage 2, which is between the 8 to 11 years. Okay. In males or females both, patient will have a pubic hair development. In females, patient will have a breast bud formation, right? And in males, the patient will have a testicular enlargement, and these two things will mark the beginning of the puberty, right? Then
Yes.
comes a stage 3, that is before 13 years, after 11 years. Okay, coarse hair will develop. Okay, the breast size will enlarged, penis size will enlarged. Okay, that is a stage 3. In a stage 4, that is before the 15 years, after 13 years, of course, patient will have a coarse hair across the pubic area, sparing of the thighs, of course, I told you. But the important thing, of course, size of the penis will increase, everything is normal. The raised areola will be seen in the stage 4. And then again, the area become, this areola will become flattened after the stage 5. And you will have the hairs on the thigh as well. And that is an important thing. So important differentiating feature of the stage 5 is uh, these hairs on these thighs and the flattening of the areola. The important feature of the stage 4 is the raised areola. Important feature of the stage 3 is nothing but just the penile and the breast enlargement. No important feature. In the stage 2, the testicular enlargement and the breast bud development are the characteristic features. Is that okay?
Yes.
Now, yeah. Give me a second. I think I've covered this already. Yes. Now you have two type of these growths or developments. One is the bone age, and second is the chronological age. Okay. Now see, you call it a puberty delay. Okay. Whenever the patient do not hit these stages at respective years. If the patient is having an age of 15 years, but is still in the stage 3 of the 10 stages, you will call it a delayed puberty. Is that okay?
Yes.
So whenever the stage and the year are not basically correspond to each other, you will call it a delayed puberty. Okay, it happens because of a transient delay in the pulsatile secretion of the GnRH, which makes sense. In order to hit the puberty, you need the estrogen and you need the androgens, right?
Yes.
If you do not have the GnRH, if you have a decreased release of GnRH, you will have a low level of these estrogens and the testosterone, and that will cause a delayed puberty, right?
Yes.
Yeah.
If the puberty is delayed, even though the chronological age is 15, you still have a 10 stages less than that. Okay, you will check the bone stages, you will check the X-ray of the patient, you will check for the bone age. That means you will check for the ossifications. Okay, because certain bones ossified at a certain time only, right?
Yeah.
Yes.
So on the X-ray, you will check for the bone ossifications. If the particular bone is not yet ossified, you will call it a delayed puberty again. Height and weight of the patient will be decreased, not correspond to that area. For example, a patient, let us suppose, according to these stages, if a patient is having a weight of the 40 years at a stage of 3, then she should be having a, in case of this delayed puberty, she would be having a weight of like only 30 years or only 30 kg or you can say 25 kg, even though she is having a stage of 3, right?
Yes.
So height and weight, it does not match again. Okay, they would be delayed by 3 months or 3 years, dependent. Okay, so it's all due to a slight decrease in the GnRS that lead to a decrease in the estrogen and LH and FSH. Okay,
Yes.
but please note, development is totally normal. It's just delayed. The bone mass is decreased, height of the patient is decreased, not correspond to the age. Okay, the hairs will not correspond to the age, or the size is not correspond to the age. So whenever you see this kind of a thing, you will think about the delayed puberty. So whenever the chronological age does not match with these stages, you will call it a delayed puberty or this thing, right? Okay.
Yes.
Yeah.
Any doubt, please ask.
No, thank you.
And now you have the precocious puberty. We have discussed late puberty. That means a very late puberty. And now let's discuss the early puberty or the precocious puberty. Whenever you have the stage 2 before the 8 years of age, that means whenever you have a secondary sexual characters before the 8 years of age in the girls and 9 years of age in the boys, you will call it a precocious puberty. It happens because, for the puberty, you need the sex hormones. So a precocious puberty happens whenever you have a increase in the sex hormone exposure or production, right?
Yeah.
Yes.
Now, I told you that these hormones, the estrogens and the testosterone, they will produce, they will cause the growth of the bone initially, the epiphyseal plate, but later on they will close it, right?
Yes.
So a patient with the precocious puberty, they initially has a very high growth spurt. They will become tallest in the class. But at the end of the puberty, okay, they will become short stature. Okay.
Yes.
And this is a very feared thing. And that will tell to the patient and to the guardians also that although she's having a very, or he's having a very good height right now, at the end of the puberty, that means at the end of the 18 or 20 years, they will become shortest in the class. Okay, step 1 can ask you this fact. They will ask you what you should tell to the patient and the guardians. So this is a thing, right? So this is skeletal maturation, a premature closure of the epiphyseal plate that can lead to a short stature. Okay. So it could be a central precocious puberty. It could be a peripheral precocious puberty. A central precocious puberty happened because of increase in the GnRS secretion. Okay, it could be idiopathic, or it could be an early activation of the HPG axis, which means the hypothalamus pituitary gonadal axis. And it can also be happens because of a CNS tumors. For the peripheral precocious puberty, it is GnRH independent. Of course, that's why it is not central. In that case, you're having an increased hormone production, one thing, or you can be having an increased exposure to the steroids. It could be a patient, it could be a teenage patient who is using all these steroids for, for the performance enhancement, right? So this could be a thing. Second thing, it could be a congenital adrenal hyperplasia, where you have a hyperplasia of the zona reticularis, right?
Right.
Yes.
And what enzymes could be inhibited?
Twenty-one alpha hydroxylase deficiency.
Okay, one thing, and
11.
21 and 11. Yeah, 21 and 11 alpha hydroxylase deficiency can lead to the congenital adrenal hyperplasia with increase in the GnRH, right?
Yes.
Then a estrogen secreting tumor in a child can lead to the precocious puberty. We will discuss later. For example, the Kansas cell tumor or the Leydig cell tumor. McCune-Albright syndrome. Remember in the biochemistry we have discussed that.
Yes.
I told you you have an endocrine dysfunction also, right? And that is a precocious puberty most commonly, right?
Yeah.
And this is an example of mosaicism. Remember?
Yeah.
Yes.
No? Yes? No?
Yes.
Okay, so mosaicism, remember the McCune-Albright syndrome. I told you when endocrine disorder will be there, and it must be the precocious puberty or a diabetes mellitus. Patient will be having a the displacement of the bone with the fatty tissue, right? The dysplasia, bone dysplasia, remember?
Yeah.
And this scapholate spot on the unilateral side of the patient body. So these are all the features of the McCune-Albright syndrome. And that's about the precocious puberty. Remember the cause: central, peripheral. Central could be due to a tumor or would be due to early activation of this HPG axis. Peripheral could be due to exposure of the external androgens. Could be due to an increase in reproduction. Internally, it could be due to a congenital adrenal hyperplasia. It could be due to any tumor. For example, a Leydig cell tumor, and these tumors will be releasing the testosterone. A granulosa cell tumor will be releasing the estrogens. You know the functions of the cells, right?
Yeah.
Yes.
The granulosa cells releasing the estrogens, and the Leydig cells, these cells will be releasing the testosterone, right? So they can cause all the precocious puberty. Any doubt, please ask.
No, thank you.
Okay, so we are done with the physiology, anatomy, and the embryology of the reproductive part. Okay, so guys, actually electricity is not here, and laptop is about to shut down. Only 5% battery remaining. So let's wind up here. Okay.
Yeah,
Yes.
sure. Thank you
Okay,
so
no
much.
problem.
Thank
Okay,
you.
we'll discuss a pathology in the next class. Okay, and we will
Okay.
finish that chapter completely in the next class.
Okay.
Okay.
Thank you so much.
Thank you.